Okay. Thank you very much for having me come to Santiago, Chile today, even if it is as a teleconference and not in person. I very much miss being there, and hopefully one day I will visit your beautiful city. The reason for me not being in Santiago today is that I am helping open a new hospital here in the Texas Medical Center. The Texas Children's Pavilion for Women has recently opened, and it is important for me to be here to monitor the opening and to actually put into practice a lot of the things that I will be talking about today. It's a strange topic, obstetrics, gynecology, and flying airplanes. And the reason for this strange topic is to get attention around the issues that have to do with the adoption of principles of quality and safety taken from the aviation industry and put into practice within obstetrics and gynecology. And so let's start looking at some of those things. If you look here, you can see that today I'm going to briefly talk about an introduction to the aviation industry, a brief history of the advances, and then specifically address a number of issues that brought us to where we are in safety and quality at the moment in our specialty. So how did the aviation industry change to address their problems? And really these issues were, okay, I'm not sure what's happening.
Go ahead.
Looks like somebody's hand is over the, okay, I've been moved. Can you still see me? Alright, I'm going to continue talking. So we'll talk about standard operating procedures, getting rid of risky practices. We'll talk about training and crew resource management, the use of checklists, and proficiency and performance monitoring. And then we'll mention a little bit about quality assurance programs. If you look at the history of the aviation industry, we can see that in the 1940s and 50s, the risk of dying in an airplane was much higher than it is today. And that because of introduction of new policies and procedures, we saw a very, very rapid drop in the number of aviation-related deaths. And so on the left side of the screen, you can see major fatal accidents per million takeoffs. And you can see that it dropped from around 8 per million down to the range of around 1 per million in the mid-1950s. And as each of these new innovations has been introduced, we've seen a huge drop in the risk of flying in the aviation industry. So these included the introduction of radar, the introduction of turboprop aeroplanes, long-range jet engines, the use of much more technology in terms of the navigational aids, and then improving navigational aids and air traffic control. But in around the 80s, you can see here that they introduced crew resource management, simulation, cabin safety, and then the protection of airplanes in flight by putting an area of a buffer zone, if you will, around that airplane. And then from then on, we've moved into refinements of these programs that have been introduced. So if you look at aircraft flight errors, you can see that they have decreased approximately 400% over the last 2 decades. And that's a significant drop in errors in aviation. When we look, however, at medicine, we see that they have increased 250% over the same time period. So something is wrong. The Institute of Medicine report in 1999 showed that up to almost 100,000 deaths occur per year in the United States due to errors, and 7,000 of those deaths were attributed to medication errors. So more of these errors were due to system errors than incompetent doctors. So it's not that the doctors are bad, but there are errors within the system that are of great concern. So why the difference between medicine and aviation? Is it possible that pilots are simply cleverer than doctors? That's one potential reason. How about, is it possible that flying a highly complex jet aeroplane is a lot easier and safer than delivering a baby? I don't believe that's the answer. I think the answer is that the airline industry has discovered something that we have not yet discovered or put into practice about safety, and we need to do that. So the first thing that we have to do is address and discuss the problems within medicine, and in this case, obstetrics and gynecology in general. And then we have to work out how other people have fixed these issues and develop the same kind of processes. It's not just the airline industry, it's also the nuclear power industry and other very high-risk industries that have addressed issues of quality and safety, developed processes, and then moved ahead in implementing those things. And it's not just a matter of checklists. It's a new culture of safety. It's a new way of thinking. So, if we, at least in the United States, look at our problems and then get together as doctors and talk about our problems, there's a lot of conversation that ends up blaming a lot of other people. We talk about the insurance companies and the lawyers and the expert witnesses, and it's the hospital administrators, and now it's the people in the medical school and their protocols, and these are the problems. But nobody ever says it's us who are the problem. And I think that this is very important that we at least state to ourselves that we are part of this problem and that it's not always somebody else's fault. And where do we look for these solutions? Well, in general, in the United States at least, it's been looking at the legal system to reform, limiting attorneys' fees, asking national organizations, and sometimes just looking to direct intervention by aliens. And I'll tell you that each of these problems, each of these solutions is likely to solve the problem, and that is have a very low chance of solving the problem. It's us who has to do something, and not for us to rely on other people. So what did the aviation industry do? They addressed their accidents by developing new technology and then determining the single best way to use that technology. And in doing that, it became very clear that they had to give up the idea of individualism, and they had to start adhering to standard operating procedures. In our case, these are protocols and algorithms, and having it so that everybody does it the same way. This doesn't mean that it can be done only one way, because we know that there are many different ways to deliver a baby or to institute a treatment or do a surgery. But in terms of the entire system, it is better to choose one way, even if it's not your way, and then everybody do that so that the nurses know and the anesthesiologist knows, and anybody else that's going to be involved with that patient will know how this procedure is going to be carried out. In the aviation industry, they were looking at something called instrument landing system, and this was introduced reasonably early. And what happens in the instrument landing system is that we have a radio signal that guides the aeroplane down a line to the landing area. And in the aeroplane itself, we have an instrument that, as long as the pilot lines up these two lines with the center, then he's in the center of this radio signal and will fly all the way down to the landing zone. And at a certain point, you must see this picture out the front of the aeroplane when you're at 200 feet above the ground in most cases. If you do not see that, you cannot land the aeroplane. It's as simple as that. And there is a procedure, and it's called an approach plate. And you can see here is an example of an approach plate. And it very clearly explains, after flying through the instrument landing system, at this point the decision height is 459 feet above the ground, which is 459 above sea level, in this case about 200 feet above the ground. If you cannot see that image, then you cannot land, and you must then climb, follow these instructions, come to this place, go into this holding pattern and wait there, asking and waiting for more instructions. So this is called an instrument approach plate, and everybody is expected to do this every single time when they are approaching in bad weather. Now, what are the obstetric parallels to the instrument approach plate that's used in aviation? Well, we need to set some minimums. In aviation, it's 200 feet above the ground. In obstetrics, with operative vaginal delivery, we have to be very careful of saying, how many times will we make an attempt with the forceps or the vacuum to deliver the baby, so that we can avoid the issue of just one more, and then disaster. So we need to set limits, and that's really what I'm talking about here. We need to have limits in our practice, and then a plan of what to do when we cannot achieve those limits. So the other one is watching the fetal heart rate strip a little bit longer. Maybe it will get better. Maybe it will get better. Let's look a little bit longer, and then all of a sudden the heart rate's gone. Or preeclampsia. Maybe I can get her another day or another week, or let's wait for the next set of labs. So I think you get the picture here. We need to set limits for ourselves and then follow those algorithms. There also needs to be a fair reporting system that allows us to address people who do not follow the procedure. And this should not necessarily be a punitive system, but if necessary, we should address every single time the procedure is not followed, even if there was still a good outcome. And the reason to do this is to determine, why did the physician not follow the procedure? Sometimes we will discover a lot about what is happening in that labor and delivery by seeing the physician behavior or the midwife behavior in terms of why they do not follow the accepted or expected procedure. And very often, if that happens a lot, we may have to change the procedure to something different. And despite this, in the airline industry, it still comes down to human beings. It always comes back to human beings, relationships, and the way people function under stress or in specific situations. So in the airline industry, pilot error still accounts for over half of fatal accidents. Why? We need to look, as the aviation industry has done, to look at our practices and make a decision to stop doing things just because they can be done. So this is the obstetric equivalent of doing a difficult mid-forceps delivery when you could just as easily do an easy cesarean section, or do a vaginal birth after cesarean section in a hospital that does not have the adequate means to take care of a patient if a complication occurs, rather than transferring that patient to a bigger facility that has the necessary facilities. Or to attempt a procedure that you haven't done in many years, rather than refer the patient to somebody who has done that procedure or does that procedure very frequently. So I think that we have to get into a way of thinking that allows us to look objectively and logically at the risks versus the benefits. Does doing this procedure in this facility, or does doing this procedure versus another procedure, or even does doing this procedure, or me doing this procedure versus asking somebody else to do the procedure, does that make more sense, and is that better for the patient? At the end of the day, everything comes down to what is the best thing for the patient, not as what is the best thing for the hospital, for the doctor, but the patient always. Now, how did the airline industry get doctors how did they get pilots to buy into this vision? How did they get some of the most aggressive and egotistical personalities? If you look at a lot of the people that were in the airline industry, these people had come from the military. Some of them had been landing jet fighters on a aircraft carrier at night in the middle of the ocean. These are not timid people. These are not people who back down from a challenge. How did the airline industry get these people to accept the new rules? Well, first of all, they made it possible to understand, or for everybody to understand, that errors occur and that it is an impossibility with humans to completely do away with all error. And so we should learn from our errors, we should learn from mistakes, not hide them. And that we can get a lot of valuable information from the mistakes if the mistakes are reported, and if thinking goes into the systematic reasons as to why that error occurred. So, how do we deal with error? And I think it's very important, if you're going to ask people to report error and mistakes, that it not be a punitive approach. So within reason, if somebody makes a mistake, and it's a mistake that could have happened to anybody else, or it wasn't done with any kind of malicious negligence, then there should be non-punitive approach. The reporting system for these mistakes should be confidential and should allow people to feel comfortable to report an error or a systems error in a way that they don't feel that they will be personally disadvantaged or attacked. And the FAA, the Federal Aviation Administration in the United States, has put out on the NASA website a way for pilots to report on themselves and in that way get immunity from the outcome of a particular transgression. So if they make a mistake, they will not lose their license. A get out of jail free card, if you will. The main aim of all of this is to allow for the collection of data so that normalization of error and the development of strategies for managing an error can take place. There is a specific model that explains the reason Swiss cheese model that explains how dangers can end up in disaster, despite our best efforts. And you can see on this slide that we can put a number of barriers between the danger and the disaster. But none of these things that we can theoretically place are without holes. There's always going to be a hole. None of these things is perfect. And in most circumstances, these holes don't line up. But very rarely, under a perfect storm situation, there's a lineup of these holes and we get the disaster. So how do we prevent this from happening? Well, there's a few ways. One is to try and make each of these things as perfect as possible, and that's probably not going to happen. The other way is to put more of these in place, which makes it a much more cumbersome system. But some combination of improving the safety of individual barriers and increasing the number of barriers is probably the right answer in terms of preventing disaster. In terms of error management, we look to avoid errors. We then want to trap any errors that we cannot avoid. And finally, we want to make whatever consequence there is of an error as small as possible. And this obviously falls into a troika or a pyramidal. We want to get the most errors we want to avoid. Every now and again we're going to miss that. Well, let's trap it and stop it from getting any worse. And finally, if it does get through, then let's have a system that allows us to decrease the outcome, the bad outcome of any error that slips through. So one of the ways that this is done is to simulate situations. And this is a big part of the airline industry and something that we at Texas Children's Hospital are very, very interested in and are moving ahead with in a very big way. Now, I don't know the training situation in Chile, but I will tell you that in the United States, residents cannot work for longer than 18 hours. There are very strict resident work hours limitations, and at the end of the day, this decreases the amount of training that our residents are getting. In order to be able to make sure that people are adequately trained, we therefore need to expose them to simulated situations so that they can recognize, avoid, and mitigate errors that can occur. So increase the awareness of problems, decrease the amount of time that is taken to recognize that a problem is occurring, and decrease the amount of time to respond to that problem, and then to continue practicing a specific scenario until it no longer becomes unfamiliar. And I think that if you do the ACLS or whatever the Chilean equivalent of advanced cardiac life support is, you will recognize that practicing this every 2 years is not sufficient. That in order to be proficient to run a code, you should be practicing this at least every month. For me, I am ACLS certified. However, at this point, it's 2 months since I got my certification. I would have to think carefully about running a code or being in charge of a code simply because I don't do it enough. And so simulation and introducing simulation is very, very important. In obstetrics, some of the urgent situations that we may have are postpartum hemorrhage or magnesium sulfate overdose or shoulder dystocia. And if we simulate this as a team, we will find that we will be able to respond to each other, recognize issues, and introduce the correct treatment a lot more efficiently simply by becoming more familiar with the process. Let's move on to a concept called crew resource management. Now, crew resource management is a system to achieve optimal performance from a team executing multiple complex tasks. And here you can see such a team of different individuals that have teamed up together to achieve a common goal. What are the principles of crew resource management? I think it's very important to be adaptable and flexible. So the team needs to trust each other and to work together. The people within the team need to feel comfortable in expressing themselves. So in a medical situation, a nurse should feel very comfortable saying to the doctor, "Doctor, I think that this is incorrect. I think you need to change. I think you need to stop what you are doing. I think we need to think about this issue." And the doctor should not get angry. The doctor should not say, "I'm the doctor, you're the nurse, I'm the boss, don't question me." The nurse should be empowered by the system to be able to say, "Doctor, it's 5 times now you've put the forceps on. You have to stop." And the doctor has to say, "Whoa, I'm sorry, you're right. We need to change, and I will do the cesarean section," or whatever it is. But assertiveness is important. That requires communication. It is a change in the system. The traditional system in the United States was always that the doctor was in charge of the situation and that everybody else would listen to the doctor. Well, the times have changed, and it is much more now a team sport, if you will, and it's very important that all of the people on that team work together. Situational awareness is important. And situational awareness is means knowing what happened 5 minutes ago, what is happening now, and what is likely to happen in 5 minutes, so that you have a big picture around the situation. We'll talk a little bit about mission analysis, and that is, what do we hope to achieve by this particular task or standard? Effective decision making, and then, as with everything, leadership makes the difference. Mr. Mark Wallace, who is the CEO of the Texas Children's System, has a saying that he has trained all of us to repeat. And that saying is, leadership determines outcomes, not some of the time, but all of the time. And I strongly believe in this saying. It is very important that there is strong leadership at every aspect of the organization. But what is an assertive statement? And this actually comes from a flying magazine, and it says, an assertive statement has 5 parts. It organizes what you need to say in a statement that, 1, gets their attention, expresses the concern, highlights and outlines the problem, suggests the solution, and then requests a response. So, in this case, a nurse says, "Dr. Gomez, I'm really uncomfortable with this baby's fetal heart rate. The variability has deteriorated. I'm seeing the decelerations. I think this patient needs your personal assessment regarding immediate delivery. Would you please come now and see the patient?" That is a statement that satisfies all of these 5 things. And Dr. Gomez then has to answer this question. And the question really is, would you please come now? And it requires a yes or a no answer. It doesn't require, well, do this or do that, or maybe we can wait. This is easy. Yes or no. We spoke of situational awareness, and we spoke about 5 minutes ago, now, and 5 minutes from now. And you can see these people are not showing situational awareness. Okay. In an obstetric milieu, we can use new PDA devices to actually monitor and follow our patients. And certainly in the United States this is now available. I'm unsure as to whether it's available in Chile, but this kind of device is coming where you can be aware of your patient's baby's heart at any time. It no longer requires that you rely on the nursing staff or somebody else to report to you the situation. It is now your responsibility to follow your patient, and you can do that from your office or from your home in the middle of the night, and this is a demonstration of situational awareness. I think it's very important for us to start to determine fatigue and performance. In the airline industry and in other high-risk industries, it's very important that people operating equipment and aeroplanes are not fatigued and are not in a situation where they can be distracted or their thought processes are slowed. This is a very interesting study that was published in 1997 in the journal Nature. They took 40 subjects and essentially they studied them over 2 days. On the first day they kept the patient or the subject awake for 28 hours. And they did computer tests of hand-eye coordination every 30 minutes. On the second day, they made the subject consume 10 to 15 grams of alcohol every 30 minutes until their blood alcohol level was 0.1%, which is very high. That's, almost 3 times the level of being drunk in this country. There was a linear correlation between wakefulness and degraded performance, to the point that after 17 to 19 hours of being awake, these people were functioning at a level of being legally drunk in the United States. At 19 to 21 hours, definitely drunk, and at 24 to 28 hours of no sleep, they were functioning at a level of being at 0.1% alcohol level. So I think that as a community and as a profession, we need to start looking very carefully at fatigue and performance and wakefulness. And we need to begin to develop our systems to ensure that we do not allow people to function when they are at a level that is compatible with being drunk. There are also attitudes that need to be identified and guarded against. I am a commercial pilot. I have instrument and commercial ratings to fly airplanes, and part of my training for the commercial pilot examination was to understand what attitudes need to be guarded against when flying an airplane. I believe that these same attitudes need to be guarded against when looking after a patient. There are some people who simply resent having anybody tell them what to do. And this is the anti-authority attitude. We have to be careful of rejecting advice simply because somebody else is telling you this. There's machismo. And we see this in some surgeons and in some doctors who take risks with a patient in order to demonstrate to their peers or to other people how good they are at a surgery or managing a patient. And what they're doing is really to demonstrate to others their competence rather than do the right thing for the patient. There is an attitude of invulnerability, and that is that this won't happen to me, this will only happen to other people, I'm too good for this to happen to me. We have to guard against that. Impulsivity, that is acting immediately with the first thing that comes to mind. Unless there's a very good reason to act impulsively, it's always best to think about one's actions, especially in an emergency situation. And finally, resignation, which I have personally seen, and at some points in my long career, I've personally felt, where you simply give up. And this is something that we have to recognize and guard against, especially when it's in relation to somebody else's life. The next thing I want to talk about is normalization of deviance, and this is a definition that we should think about and understand. Normalization of deviance is the degradation of professional or technical standards based on individual experience and the fact that non-adherence to the standard infrequently results in an adverse outcome. And what this means is that we allow behaviors to occur because bad outcomes are not common with that behavior, such that as the system progresses, even though people recognize that this is an unsafe practice, it becomes the normal practice in that institution. So an example of this would be allowing a mid-forceps delivery to occur without having an anesthesiologist or a team ready to do an emergency cesarean section if needed. And what happens is that most of the time you don't need the cesarean section. And so people stop calling the team and they do the mid-forceps. And at the end they say, oh, well, we didn't need the team, so this is now our new standard. We don't need them. And so in the eyes of the people within that system, this has now become the new normal. That is normalization of deviance. People that are subject to normalization of deviance make statements like, I've always done it this way, I've never had a problem, therefore this is the way that we will do it. That is not the correct way. That is a way of thinking we need to stop. So David Grimes, who is a very, very senior and well-supported individual in the United States, says that there is seduction by authority. And very frequently this is the very senior person who says, this is the way that we must do it. I don't want to hear about anybody else's ideas. This is the way that we will do it. This is seduction by authority, where it may not be the right way, or that very senior person may not be keeping up with practices, may not understand new techniques, but says, I'm the boss, you do it my way. That's seduction by authority, and that's not the correct way to do things. And within the nursing purview, there is a statement made by Kathleen Rice Simpson that there is acquiescence of nursing staff to practices they deem unsafe. So even though the nurse realizes or thinks this is not good, this is not safe, she still does it because the doctor told her to do it. Therefore, I'm doing it. And again, this is not the modern way of looking at issues. It is not the correct way, and it is not crew resource management. Now we move on to talking about checklists, and I think that this is just a small part of what I wanted to talk about today. Checklists are very important. We don't need to have a checklist for everything, but we do need to have a checklist for things that in the aviation industry are called killer items. That is something that if you do not do it, there's a very, very high risk that you could end up in a bad outcome or a crash of the aeroplane. And so there are specific checklists and practices, and there are checklists to deal with emergencies. So in the case of flying an aeroplane, there is an engine out checklist, i.e. what should you do if the engine suddenly stops? Obviously, if you're in an aeroplane with one engine, this is a terrible emergency. If you're in an aeroplane with two engines, you may have a little bit of time to get things right if you do things correctly and in the correct order. But a disaster would be if somebody panics and then switches off the other engine by mistake. So there are checklists that allow the person to then perform the correct standard procedures in order to try and get the engine restarted. Well, what does a checklist do? A checklist in the case of medicine, allows a standardized logical verification of the patient's condition. What exactly is going on with the patient? It allows mutual supervision or cross-checking. This is very, very important. In very high risk, very high stress situations, it is important that the people dealing with that situation cross-check each other's decisions so that you don't have somebody, one person who is in authority making one bad decision and then the entire code or the entire process is predicated on a bad decision and goes down the wrong algorithm. So it's important, and this comes back to the crew resource management, that people are able to talk to each other and question each other and make sure when you're doing something that it's the right thing. The checklist also makes it clear to each of the people on the team what their particular job is. What is their coordination and workload distribution. It also keeps people that are on the team in the loop, and it allows for quality control. In the case of the aviation industry, government regulators, and in our industry, it'll be the medical teams. So what are the killer items that lend themselves to checklists? Well, how do we manage an abnormal fetal heart rate tracing? How do we give oxytocin? How do we give misoprostol or this other drug, magnesium sulfate? How do we deal with these issues? So these are things where there can be tremendous problems if not managed correctly, and they lend themselves to the use of a checklist. This is an article that actually talks about how to go about putting together a checklist. And it talks about identifying the need for the checklist, making sure that there's a goal for this checklist and a group of people to whom the checklist will be of meaning. Then develop the content, make sure that all of these issues are considered, test the checklist, review the checklist, get the necessary approval, make sure that the people who are going to use the checklist are adequately educated, and then frequently review and make sure that the checklist is satisfying the purpose for which it was developed. So it becomes very obvious that developing a checklist is not a thing that one person does. It's not a system where one person says, oh, here's your checklist, from now on everybody just follow the checklist. If you use that methodology, you will fail. Because at the end of the day, the people who use the checklist are the people that need to be consulted and need to help in the design of the checklist so that they can use it efficiently. On the left side of the screen, you will see a checklist for an MD-80 jet, a McDonnell Douglas jet. And I don't expect you to be able to read it, but what it shows is how to do things in a specific order so that everything is done correctly. And on the right side of the screen, you see a checklist that was designed for acute cardiac life support and for dealing with ventricular fibrillation, a medical checklist, if you will. Why do people decide against using a checklist? Well, they think that it may be too cumbersome. There may be people that just want to be unique. They don't want to do what everybody else does. They want to show the world that they can do it their way. And then there are people who simply want to demonstrate that they are better than everybody else. And this gentleman used to be the chief pilot in the United States Air Force. And he got into his aeroplane and did not follow the checklist, did not set his altimeter, and as you can see here, he saved his life, but he destroyed an aeroplane that cost many millions of dollars, and ultimately he lost his job as chief test pilot, simply because he did not set his altimeter to the correct height. He missed one checklist item. So it's very important in checklist development to eliminate ambiguity. And unfortunately, in our industry or in our vocation, we often have protocols that allow us to do, at least in the United States, to do the same thing very many different ways. So it's important in a system to sit down and make a decision about what is the one single best way to do this, and then everybody follow that. Now, the Institute of Medicine has designated magnesium sulfate and oxytocin as two high alert medications, two drugs that we use frequently in obstetrics and gynecology as high alert medications which represent significant danger. My partner and I and a number of other people, you can see, wrote a paper back in 2007 that dealt with implementation of a checklist-based protocol for the use of oxytocin. And we had a lot of criticism about introducing this because basically it had two checklists. It had a checklist that said you have to follow these criteria before you can start the oxytocin, and then every 30 minutes during the use of the oxytocin you have to go through the checklist and make sure that these criteria are followed. It wasn't very onerous, but it did increase the amount of work, and people were very skeptical. So we published our results, and what we showed was that the total time of infusion was actually decreased when we used the checklist, that the number of cesarean sections, no change, and that the babies going into the intensive care unit decreased. I'm sorry, no change in the time for total amount of oxytocin used. And these were the two criticisms that people had. They said, you're going to make us use this checklist and we're going to spend a lot longer, much more time getting the patient delivered. And they said, we're going to do a lot more cesarean sections because if you don't let us increase the dose quickly, or if you don't let us use it any way we like, then we're not going to get the optimum use of the drug. And when we showed them the data, they were shocked. But this is a case where we instituted a checklist and actually showed significant improvement. This was the period that we introduced the checklist, and the cesarean section rate, which in a very large system, 220,000 deliveries per year, decreased and has continued to decrease and then flattened out. So in one system within the United States, by the introduction of a simple checklist, we were able to significantly reduce the cesarean section rate. And there are other safety checklists that have been used in intensive care units. And here's one that was used simply to check central line, sedation, glucose, just a number of things that were being done inside the intensive care unit. And what did they show? They showed that before and after implementation of this checklist, they showed that the line-associated sepsis rate was significantly decreased, and that the ventilator-associated pneumonia rate was significantly decreased from 16% to 8.9. The mean monthly line sepsis rate significantly decreased, and so did the self-intubations, by simply introducing a checklist. One of the other things that can be prevented is loss of critical information, and preventable deaths due to errors account for up to 10% of deaths in a level 1 trauma center. 50% of these errors occur in the intensive care unit, and in 67% of the sentinel events, the errors are due to communication errors. So here's a study where they did an observational period that were the control group. They then introduced a teaching session on the science and use of a checklist. And this was used for all patient handoffs. And they then tracked a 24-hour period and all of the handoffs. And what they showed was that this simple checklist, patient management plan checklist, resulted in a significant drop in all of these areas. Critical laboratory test results where errors in communication were reduced from 36 to 4.5%. Errors in antibiotics and cultures and medications from 11% to 1%. Errors with nutrition, ventilation, other issues significantly reduced. Tubes reduced. And the total number of errors was reduced from 20% to 3.6%. Very, very important issues. So I think that I'm going to finish at this point and leave you with 5 principles that were taught to me by my mentor, Dr. Stephen Clark. Process. It is important to institute uniform process because that often and almost always will result in improved outcome. Pure physician autonomy is an antiquated and dangerous concept, and we've spoken about how it's more important to work in a team than to have the physician as the one and only authority. Every member of the team is empowered and obligated to stop dangerous care. Caesarean delivery is a process, not an outcome endpoint, and if it makes more sense to do a caesarean delivery, then do the caesarean. In the United States, at least, litigation is best reduced by reducing bad outcomes and by improving documentation. And it is very important to have effective peer review. And this is something that I did want to talk about in terms of being able to police ourselves and to take the necessary steps to review bad outcome cases and to discipline physicians and nurses and make sure that the patient is put at the top of that pyramid. And I will stop at that point. Thank you. Are there any questions?
Applause.